I would like to invite now our speakers to the podium to take questions from the audience. We have two assistants, I believe, in the audience with microphones, wireless microphones. So if you have a question, please step into the aisle and they will handle the microphone to you. If you prefer, we have a way to ask questions through Twitter, so you can ask questions that way too. I guess we have no additional room for Dr. Roski, but if there's a question for Dr. Roski, I'm sure he'll be delighted to come up here and answer your questions. So any questions from the audience?
Just as our questions are beginning, let me remind you that a lot of these questions are, a lot of these topics are very complex and some are simple. But I want to remind you that your local radiologist, as well as the UT Southwestern radiologist, should be asked these questions when you're deciding whether or not to image. So you can reach us by calling 214-645-RADS. We are happy to answer any questions that you might have about these topics today and after today, so that we can optimize the imaging experience for your patients, so we can do the right test for the right patient at the right time.
Good morning. My name is Lyle Callister. I'm an internist, been in practice in Dallas for 42 years. And this may be a question for Dr. Roehrborn. We're living in an era of the low T syndrome. So my 55-year-old male patient comes to me and says, "Doc, I'm gaining weight, I'm losing muscle mass, and I'm losing my passion for making love. I think I've got low testosterone. I want you to check it, please." I say, "Okay, managed care may not pay for it, but if you want it," he said, "I'll pay for it." So I get a serum testosterone level, and it's 350. So I say to him, "Well, you know, that's low, normal, but you're 55. He says, "Doc, I want you to give me testosterone so I can develop my washboard abs again, lose weight, and feel passion." All right, so my question is twofold. Number one, if this 55-year-old man has a nest of inactive cancer cells sitting in his prostate, or some early active cancer cells sitting in his prostate, giving him 6 months trial of testosterone, is that going to adversely impact those cells, the growth of them? And number two, at what age for a male would you suggest not even checking a testosterone level because he's gaining weight, losing muscle mass, and losing his passion to make love?
Okay. Good question. So we are, Dallas-Fort Worth used to be, still probably is one of the epicenters. I think we had at one time 23 low T centers, and these are just testosterone mills. In the interest of time, I just want to try to be very focused here. First of all, there is not really any scientific evidence that the administration of exogenous testosterone either initiates prostate cancer or accelerates the growth of prostate cancer, makes lower urinary tract symptoms worse, or drives up the PSA systematically. In fact, there is a paucity of good studies, but the few studies that exist would negate that actually. So when I have a patient of this nature and he wants to be on testosterone, I'll say, good, we'll do this, but we'll check your PSA, testosterone, and hematocrit, and I set it up as a standing order because you got to guard against the whole erythrocytemia issue. And I ask him to repeat those tests at 3 months and at 6 months, and then I'll have a repeat visit and discuss with him these findings. But there is no evidence for that. Having said that, you will run across some patients who take their first 1 or 2 or 3 testosterone shots or the gel, and suddenly their testosterone shoots up. These are outliers, and I see them, and others may have seen them, and they will require a referral. In those patients, it's either that the PSA thermostat is set very low because of a long-standing low endogenous testosterone level, and then it suddenly shoots up, or in those patients there is something going on that requires imaging plus minus a biopsy. But there is no systematic evidence for impact on PSA prostate cancer or activation of prostate cancer. So that fear is probably not well founded. And I'm not going to talk about the whole malaise of these cardiovascular issues and the pros and cons, and which is also a big morass, as you know. The second question is, would there be an age where I wouldn't do that? Well, I mean, testosterone levels decrease in men when they age in a sort of linear fashion. And I'm not sure that I would exclude a man based on age from allowing him to have a testosterone checked. I wouldn't do that. The last issue is you brought up a patient that's kind of peculiar because his testosterone was 350, and by most laboratory reference ranges, that's normal. And I categorically am not in the business of driving testosterone above or from a normal range to a high normal range. I'll just refuse doing that. So, as you know, there's sort of an inflation going on by which the reference ranges move up, so that patients with higher and higher testosterone are still eligible for testosterone supplementation. And I think that just doesn't do really a service to the population. So I don't do that in those patients. I refuse doing it. And if it's too low, meaning in the lowermost 10 percentile, let's say, or below the level of normal, then I engage in that treatment with checking the PSA, checking the hematocrit 3 months, 6 months, and revisiting with the patient.
Thank you.
All right, any other questions from the audience? So while we wait, oh, there's one back there.
I have a question about PSA acceleration. The way the PSA goes high every year, is that a big factor in decision making? I guess this question to the urologist.
So this is a PSA velocity question that you're asking. So there's a very famous study many years ago published by Bell Carter in the Journal of Urology that found that basically a PSA velocity of 0.75 per year increase from baseline is most predictive of the presence of prostate cancer. So this, however, does require you have 3 measurements, and I would argue that this paper is a little risky because it's not based on a very large number of men. This is a paper that came out of the Baltimore longitudinal study of aging. Frozen serum specimens in a big warehouse somewhere in the Baltimore harbor were unthawed and looked at, and in the end they had like a few dozen patients on which to base this assumption. Plus, there is a risk in making this velocity assessment. If a patient starts with a PSA of 3, I would say that's different than when he starts at 1 or he starts at 5, the 0.75. So I don't advocate a single velocity number. Having said that, there is also no question that a PSA in a well-lived life should increase a decimal point a year. So if a man at 50 has a PSA of, or 40, let's say, has a PSA of 2, at 50 it's 3, at 60 it's 4, at 70 it's 5, that's a well-lived life, a decimal point a year. But any BPH, prostatitis, and anything can upset the apple cart. So you just have to sort of take some chances. If a patient has a PSA that increased from 1 year to the next, I would first repeat it within a month or so to make sure that is a real increase and not driven by, for example, sexual activity or some other activity that could drive it up. If the second value again verifies an increase and you're uncomfortable with it, I would make a referral. If you have a longitudinal tracking and you have 3-4 year data and you're uncomfortable with the rise either as a percent or an absolute number, make a referral. But do consider that the base level of PSA is important, and an absolute increase may not be your best guide in this respect. The reference ranges that I gave you, less than 2.5, 2.5 to 4, kind of yellow, over 4 being red, they are in line with the American Cancer Society. I find those the most sane recommendations at this time, and I would urge you to consider those as being something that you keep in the back of your mind. And if the patient enters those ranges, then I would pull a trigger on a referral.
Go ahead.
We have one question for Dr. Diaz de León. We've heard about spectral imaging as a way of, or spectral CT as a way of eliminating the need to do 2 scans to get the with contrast and the without contrast on renal cyst assessment. Can you speak to that?
Oh, sure. So I started to speak about that on the last slide, but to go in a little more. So usually the way we evaluate these, like I was mentioning, we get multiple phases, and again, to make sure that there is no enhancement. But with spectral CT, with dual energy CT, we're actually able to eliminate that non-contrast phase. And so what that means is one less study or one less acquisition, so less radiation. But we are routinely using that now.
I have one more question. Are we going to use these technologies as a future screening for prostate cancers, the advanced technologies, eliminate, get away from PSA and digital rectal examination, but use any technologies as a screening tool, as a population screening tool in future?
Sorry, we're having a hard time hearing the question from here. Maybe you can put the microphone closer or come to one of the other microphones.
I'll repeat the question again, I'm sorry.
Thank you.
Using technology as a screening tool for prostate cancer, get away from PSA and digital rectal examination in future.
So the question is for imaging technologies or some of the other tests that were listed in Dr. Robert's presentation?
Any technology that you have mentioned, is that going to be a future possibility of a screening tool for population?
So maybe that would be 2 questions, one for Robert and one for Dr. Costa. Do you think any of the technologies that are on the horizon are going to be helpful in screening for prostate cancer beyond what PSA can do?
Well, I can start by talking about MR. I think it is difficult to think of MRI as the initial screening test. As of today, there is reliable, good quality data to support MRI as a pre-biopsy screening test after a clinical assessment that leads to suspected prostate cancer status. And that is based on the value of MRI as a risk stratification exam. By that I mean avoiding unnecessary biopsies in patients with normal MRI, or rendering the patient or directing the patient to the appropriate treatment by preoperatively or pre-treatment offering the correct tumor risk assessment. But if your question is, are we going to do MRI to replace PSA, I don't think we have data to substantiate that as of today.
Dr. Robert?
I agree with that. There is a study that was done using a upfront MRI for a population-based screening, and they showed, weirdly enough, that it performed better than PSA. But that must have been a very select patient population. I think the cost factor is prohibitive, and I just couldn't imagine it. And I think the key to succeeding with MRI as a test prior to a biopsy is the negative predictive value. If the negative predictive value is very high, very good, and reliable, then urologists will stop doing biopsies. And if you'll eliminate 30% or 40% of biopsies because the MRI gives you that confidence, I think then it may enter the realm of possible cost effectiveness. But that's the caveat. It has to be a very good and very reassuring negative predictive value.
Thank you. I guess we have other questions from Twitter.
We have a question for Dr. Bailey. In a patient who has an ovarian cyst and is having pain, is there a need to repeat that imaging over again?
So based upon the imaging, it would depend on what it looked like, but the pain feature means that it needs to be assessed by somebody who can address it surgically. When you decide if an ovary is torted, that is a clinical exam finding. And so if she is having pain and has a mass in the ovary, that's something that needs to be addressed immediately. Then based on that surgeon's perspective, we could offer follow-up, and it would fall back to the asymptomatic if the surgeon determined that that pain was related or not related to the cyst.
One more question?
Yes. This question is for Dr. Roehrborn. Does the use of alpha blocker or Flomax for BPH have any effect on misguiding the diagnosis of prostate cancer since it lowers the PSA?
Well, that person must not have read my pivotal paper from 1994, which was the first paper that examined this in a cohort of 1,000 plus some odd men who were given terazosin for 1 year's duration and had zero change in their PSA. And this finding has not changed since then. Patients on alpha blockers do not experience a change in their prostate size, shape, configuration. It continues to grow. The PSA continues to increase in the same manner as it would otherwise, a decimal point or two per year in a normal man, and there is no impact, despite some basic research suggesting alpha blockers induce apoptosis, but it's irrelevant clinically. It does not affect it. Quite in contrast, and I just add that real quick, to finasteride and dutasteride, you'd have to be careful, a 50% reduction in PSA, a common cause of lawsuits in the United States, that the use of finasteride and dutasteride for BPH is overlooked, the PSA is misinterpreted, it has to be corrected. The most common problem is young men who receive Propecia, 1 milligram for alopecia, male pattern baldness, and there is also a pivotal paper by Dr. D'Amico and myself looking at the Merck database with Propecia. Propecia will induce a 40% reduction in PSA. This is commonly overlooked because it's a lifestyle drug. It's done by dermatologists and by hair restoration centers, and oftentimes the primary doctor doesn't even know the patient is taking Propecia. So I alert you all to watch out for that. 1 milligram of finasteride, which is Propecia, also lowers the PSA by 40%.
All right, I think we are out of time. As you know, we have a busy schedule today. So our panelists are going to be available outside. If you have any further questions, we're going to take a 10-minute break. I just want to remind everybody that we have breakout sessions 2 and 3 in the adjacent rooms. And we're going to take a little shorter break than we were going to because we're a little behind. So we'll start at 10 again, maybe 7 minutes. And you'll hear the sound of the chime just to announce the reinitiation of the session. Thank you very much for the speakers and for you, your audience.